Hello everyone and welcome. The next topic that we will be covering in Anatomy and Physiology 1 are the skeletal muscles. Now there are a few subtopics that we will also talk about within skeletal muscles, but the major goal for this set of PowerPoint slides is to be able to identify skeletal muscles, and we will work our way there. However, there are a few other topics that we must cover before we get to skeletal muscle ID, and the first of those is articulations. Articulations, as we've discussed in previous presentations, refer to the locations where two bones come together. Articulations also refer to our joints. The benefit of articulations, of course, is movement. Where two bones come together, we can form a joint, and our bodies can facilitate different movements. However, the downside regarding joints is that these do tend to be the more weaker parts of the skeleton. Joints, being the locations on our body where we can facilitate movements, can be classified both structurally and functionally. The structural classification of joints refers to the specific materials that can be found present at the joint. And the functional classification of our joints is based on the degree of movability of a particular joint. So to classify a joint structurally, we use two different pieces of criteria. Specifically, the binding material, or the connective tissue that participates and is found at the joint, and also whether or not there is a synovial cavity. And I should probably mention that of these two factors, we want to assess the presence of a synovial cavity first. There are three types of structural classifications to our joints: fibrous joints, cartilaginous joints, and synovial joints. Each of these joints will either have or will not have a synovial cavity, and will have some type of connective tissue that brings the joint together. So we'll first ask the question, which of these three types of structural joints have a synovial cavity? And the answer to that is that the synovial joints will have a synovial cavity. And in fact, synovial joints will be the only type of joint that will have a synovial cavity. We also must remember to include the binding material to our joints, so synovial joints will have a nice, dense, irregular connective tissue that holds the joint together. It is this dense, irregular connective tissue that makes up the walls of the synovial cavity. Now, we also have fibrous joints and cartilaginous joints. Neither of these two structural classifications will have a synovial cavity. So we must distinguish these two types of joints based on the binding material that's present at the joint instead. Fibrous joints, as they sound, will have dense fibrous connective tissue. That is our dense, irregular connective tissue, while cartilaginous joints, just as they sound, will have cartilage that's found at their joints. There are a couple of subsets of fibrous joints and cartilaginous joints, but you'll go over those a little bit more in your lecture class. Fibrous joints can be further broken down based upon how much connective tissue is found at the joint. Joints that have very little connective tissue are not going to be very movable. However, joints that do have more connective tissue will have the freedom to move around a little bit more. Cartilaginous joints can be further broken down into the type of cartilage that's found at the particular joint. A synchondrosis is a type of cartilaginous joint that's joined by hyaline cartilage, while symphyses are cartilaginous joints that are fused by fibrocartilage. Again, I don't want to stress that too much, you'll get that more in your lecture class, but I do want you to understand how we structurally classify our joints, based on the presence of a synovial cavity and by what type of binding material is present at the joint. Now, in terms of the functional classification of our joints, we're going to look at how movable the joint is. We have three functional classifications, namely a synarthrosis, an amphiarthrosis, and a diarthrosis. Each of these classifications are classified based on their degree of movability. Synarthroses are not very movable. In fact, they can be defined as immovable, where no movement is permitted at all. Diarthroses, on the other hand, are just the opposite. These are freely movable joints, and joints that fall into this group are our shoulder joint, elbow joint, the knee joint, and the hip joint. Just something that we can all be aware of is that all diarthrotic joints are also synovial joints, and all of our synovial joints will also be classified as all diarthrotic joints. So a synarthrosis is a functional classification that includes all of our joints where there's not going to be any movement. And diarthroses are going to be all of the joints where there is a lot of movement facilitated. An amphiarthrosis sits somewhere in between these two other functional classifications in that these are slightly movable or moderately movable. So based on the material that's actually present at the joint, the physical structure of the joint, or how much movement is permitted at the joint, we get our structural and functional classifications of joints. Now we want to think about joints in terms of muscles. That is what this chapter is about after all. One very important fact about muscles is that muscles will cross over at least one joint. Muscles only contract. Muscles never forcefully lengthen. So if we're going to exert a force from our muscles, that force is going to shorten the entire length of the muscle, never to elongate the muscle. In order to elongate a muscle, all we can do is relax it. So it is because muscles will shorten in their length that muscles will span at least one joint. Our skeletal muscles give us the ability to move our limbs around. And this is only possible because we're able to pull on the movable parts of our bones and use those joints to our advantage. So while there are 3 different types of muscles, skeletal muscles, cardiac muscle, and smooth muscle, we're going to mention all 3. However, this presentation is primarily going to focus on the skeletal muscles and talking about how the shortening in the length of our muscles will move our skeletal system around. So this would be a good point for me to mention that if you are not already aware, there's a difference between tendons and ligaments. Ligaments attach bone to bone, and tendons attach muscle to bone. It is specifically muscle tendons that allow our muscles to attach to the skeletal system, and that of course is where our skeletal muscles get their name, because they attach to the bones that make up the skeletal system. So specific tendons will be found on each side of the muscle, attaching the muscle to our bones in certain places. And again, those attachments will be strategically placed to allow for movement at certain joints. The common conventional words that we can use to describe the attachment points of muscles to bones are listed here, specifically the origin and the insertion of the muscle. The terms origin and insertion are based upon specific movements. So the origin of a muscle is the attachment location of a muscle to the bone that does not move throughout the action of that muscle. The insertion, on the other hand, is the attachment to the bone that does move when that muscle is carrying out its major action. So you see, we're looking at the biceps brachii muscle. This is the muscle that can be found on the anterior side of the upper arm. The biceps brachii muscle will have origins up here on the scapula and an insertion down here on the radius. This muscle in particular will span 2 different joints, and therefore when this muscle contracts, it's going to bring the origins closer to the insertion. As long as the tendons are connecting the muscles to the bones, the contraction of this muscle will facilitate a muscle movement. And we have lots and lots of muscles that can be found in our body, and each muscle will serve a slightly different purpose based on where it can be found and the locations of its origin and insertions. One other way that we often refer to origin and insertion is the proximal attachment and the distal attachment. Most of the time, the origin is just another way of saying the proximal attachment, and the insertion is another way of saying the distal attachment. I won't be testing you on proximal and distal attachment, but I just want you to be aware that those are some other terms that we can use to describe the locations where muscles attach to bones. So now that we've discussed how muscles attach to bones and how muscle contraction shortens their overall length to provide movements, we will now move into some of the specific movements that our bodies can facilitate. We need to be comfortable with each of these movements, as each individual muscle will have a certain action and facilitate one or more of these movements. So let's go ahead and get started explaining the difference between flexion, extension, and we'll also include hyperextension in this first group. There are 4 major groups of movements, namely angular movements, rotational movements, gliding movements, and special movements. Flexion and extension fall into the category of angular movements. Angular movements can be defined as any movement that will increase or decrease the angle between 2 articulating bones. I've just drawn a couple angles here to demonstrate this point. Anytime we take 2 bones at an obtuse angle and make the angle between those 2 articulating bones more acute, that's going to be a type of flexion. And vice versa, we can also take the angle between these 2 bones and increase it to make it more obtuse, and that would be an extension. So this is a fabulous joint that we can see demonstrating a flexion and an extension. The bones articulating here are the humerus, as well as the ulna and the radius. So specifically, we want to look at the angle between those articulating bones. And if we're going to decrease the angle between those bones, that's considered a flexion. And if we increase that angle between those articulating bones, such as in this picture here, we will see that this refers to an extension. As we have gone from this depiction to this depiction, we have taken this angle and significantly increased it. Therefore, we're looking at an extension. Now, many different joints can have an extension. We can do this here with the hand, we can do this with the entire arm, with the neck, and also with the legs as well. You can even have lateral flexion where you decrease the angle going towards the side. Any type of increase in the angle is going to refer to an extension up to 180 degrees. However, if we do go past 180 degrees, we're going to classify that as a hyperextension, and we can see that here with the leg. Certain joints will facilitate a hyperextension much more naturally, such as up here with the shoulder joint and over here at the hip. But a hyperextension is not as good of a thing here at the elbow joint, and it would also not be a great thing here at the knee joint either. So you can see that this slide will really show you that as we increase that angle between those two articulating bones, we see an extension, and as we decrease that angle, we're going to see a flexion. The next two terms that we're going to introduce are abduction and adduction. Abduction and adduction are often confused with each other because they are spelled so similarly. We often will refer to this as abduction and this one as deduction to make sure that we have not confused these two terms. An adduction is when you move a structure closer to the midline, while an abduction or an abduction is when we move structures away from the midline. So we have to make sure that we are drawing a midline down the body in order for us to see an abduction or an adduction. You can see that we can abduct the arm by holding the arms out, and we can pull our arms back into our sides, and that would facilitate an adduction. You can do the same thing over here with your leg. As we adduct the leg, we're going to bring our leg closer to the midline. And as we abduct the leg, or abduct the leg, that's going to be taking the leg further away from the midline. Now we can also draw a midline down the hand as well, right down the middle finger. And you can see that we can abduct the hand, and we can also adduct the hand as we bring the hand closer to the midline. Additionally, we can do this with the fingers, where an open hand is going to be an abduction, and when we bring all of our digits closer to the midline, it's an adduction. So a little way that you can remember abduction versus adduction is that with adduction, adduction, you are adding all of your structures towards the midline. Everything is being added together, and therefore you're bringing them closer to the midline. While an abduction sounds like abduction, and when someone or something is abducted, it is taken away from where it is supposed to be. I know that sounds a little grim, but that's a little trick that I have always used to remember the difference between abduction and adduction. Hopefully it helps you too. A couple other types of movements that we will also see is circumduction and rotation. Circumduction is a very specialized movement, and rotation specifically can be classified under our rotational movements. Let's discuss rotation first, as that is a movement that we will see much more commonly. A rotational movement is when a long bone rotates along its longitudinal axis. I know that this is a very simplistic picture that I have just drawn here, but hopefully this demonstrates to you a rotational movement. We can see both medial and lateral rotation being facilitated with the humerus. The humerus is not changing its spatial position very much at all. However, it is rotating along the length of the bone. Therefore, medial rotation is shown with this arm as we bring the hand more medially. And lateral rotation is just the opposite, where we bring the hand outwards. You can facilitate both medial rotation and lateral rotation with the leg as well. We will come to see that both medial and lateral rotation are very common actions, especially for the rotator cuff muscles. Circumduction is a very specialized movement, and we won't see any singular muscles facilitating this movement. Circumduction is when you take one of your extremities and move the distal end in a circle. Circumduction can be defined as the repeating movement of an abduction, flexion, adduction, and extension. So these are 5 very, very important movements. Flexion and extension are angular movements that refer to an increase or a decrease in the angle between two articulating bones. Specifically, flexion refers to a decrease in the angle between articulating bones, and an extension is the increase in the angle between two articulating bones. A hyperextension is when we extend past 180 degrees. Abduction and adduction are movements where we bring a body part either closer to the midline or further away from the midline. We remember, with adduction, we are adding to the midline. With abduction, we are taking away from the midline. And a rotation is where a bone is turned along its longitudinal axis, as we saw with medial rotation and lateral rotation. So we've now seen a couple angular movements, and we've seen a couple rotational movements. We also did have gliding movements and special movements, and we'll see special movements on this slide. Gliding movements aren't going to be discussed as much. Those are the types of movements that occur in the wrist. But we want to more specifically focus on our special movements that are listed here. Special movements are very, very unique in that they only typically occur at one joint. For example, pronation and supination only occur at the hand, while inversion and eversion only occur with the feet. I will discuss each of these special movements in their respective orders. Pronation and supination can be shown here with the hand. I often think of pronation and supination as a rotational movement with the forearm. Both of these movements only occur with the forearm. Supination is what we're doing in the anatomical position, where we turn the palms of our hands anteriorly. This conversely causes the backside of the hand to be pointing posteriorly. Pronation is just the opposite, when we take the palms of our hands and rotate them to point posteriorly. A little way that you can remember pronation versus supination is that basketball players will have to pronate their hands to dribble a basketball. And this is a little corny, but with supination, as the palms are going to be facing anteriorly, you can hold soup in your hands when your arms are supinated. We will come to find that there is a muscle known as the pronator teres, and that muscle is primarily responsible for pronating the hand. We'll also find special movements here with the feet, namely inversion and eversion. Inversion is where we tilt our feet medially, and eversion is where we tilt our feet laterally. Our last set of special movements refer to dorsiflexion and plantar flexion. So we must remember that the hands and the feet are anatomical equivalents of each other. The plantar region of the foot referred to the sole of the foot, and that's the anatomical equivalent of the palmar side of the hand. Plantar flexion is where we decrease the angle between the plantar side of our foot and the bones that are making up the leg, namely the tibia and the fibula. So as we stretch out our foot, we bring the plantar side closer to the tibia and the fibula. Dorsiflexion is just the opposite and refers to the dorsal side of the foot. Despite this being the superior part of the foot, we also call this the dorsal side of the foot. So dorsiflexion is when we decrease the angle between the dorsal side of the foot and the tibia and the fibula. Since these are referring to flexion, that indicates that we're looking at a decrease in the angle between those articulating bones. So pronation and supination are special because they just deal with the hands. As we turn our palms anteriorly, that's supination, and that's how our body is in the anatomical position. And as we turn our palms posteriorly, that's referring to a pronation, and that's how basketball players will dribble a basketball. Inversion and eversion refer to the tilting of the feet, either medially or laterally, and dorsiflexion and plantar flexion go within the same plane. These refer to the movements of our toes and the upper and lower sides of the feet. Dorsiflexion is when we bring our toes up. This would allow us to spread out our toes. And plantar flexion is when we curl our toes and point our toes outwards.